Hello, welcome everyone. Welcome to OSC Colloquium. My name is DK Kang, Associate Professor here at College of Optical Sciences. Today, we're very excited to have Dr. Zeinab Hajjarian. She's an Assistant Professor of Biomedical Engineering at the University of Massachusetts Lowell. She received her PhD in Electrical Engineering from Penn State University in 2009. Her PhD work was more about modeling light propagation in the turbid and turbulent atmosphere. Then, she transitioned to the field of biomedical optics in 2010 when she started her postdoc position at the Wellman Center for Photomedicine at Massachusetts General Hospital, and that's how we came to know each other. Since then, she has been focusing on developing novel laser speckle micro-rheology techniques for rendering and imaging the biomechanical properties of the tissue. So I'm very fascinated about her research because this is very unique in optical in the technology where you can figure out mechanical property without touching it, just using, how speckle behaves over time. You can kind of figure those things out. So, well, I'm not going to steal, anything from Zeinab's in the presentation. So with that, Zeinab, please go ahead.
Well, thank you, DK. Thank you very much for the nice introduction. And I just want to add that I just started at UMass Lowell in September. And what I'm going to be presenting today is the research that I performed back at Wellman Center for Photomedicine during my postdoc and my instructor years at Wellman. So I'm hoping to continue doing the research of the same caliber here as an independent professor here at UMass Lowell. But the credit for the research goes to my former mentor, Dr. Samantha Nadkarni at Mass General. And this is a technology that started in her lab and, just flourished to this imaging modality. So with that, I just want to give you an outline of my talk. So today I will be talking about laser speckle micro-rheology, and I'm going to start with the application side. I'm hoping that I don't bore you too much with the biology of things, but I just want to put things in perspective, why we care about measuring mechanical properties and why we choose optics to do so. And just put this technology in the context of existing optical elastography modalities, and then going forward with how we manage to measure mechanical properties in this way. And what factors we kind of corrected for and considered in these calculations, and how the matured and prime technology was then applied to this specific disease model of breast cancer that I'm going to be presenting throughout this work to basically find some connection between mechanical properties of the tissue that is like a research grade quantity and on one hand, and on the other hand, the prognostic known markers that are used currently in the clinical practice, and then end with the prospect of, measuring these kind of biophysical quantities that have been pretty well established in the context of tumor biology studies, but have not been translated in the clinical setting. So maybe by using optics, we can open new avenues for, translating these concepts, these biophysical and tumor biology concepts to the clinical setting and help with shifting the paradigms of cancer diagnosis and treatment in the future. So I'm going to start, as I promised, with the mechanobiology of breast cancer, and I hope this is going to be a shorter introduction. So the idea is that this is the disease model that we use. This is the cancer that develops in the ducts and lobules of the breast tissue, and this is the second major cause of cancer-related death among women worldwide. And basically, the idea is that the normal breast anatomy is composed of epithelial cells that are arranged in this around the central lumen in the circular and acinus kind of structures, and surrounded by my epithelial cells, and they are encased by the basement membrane layer that separates this functional glandular component of the normal breast anatomy from the stromal component that is usually composed of wavy, soft collagen fibers. That is considered the stromal component. And then this whole thing is in the context of a lot of fibroadipose tissue that basically comprises the majority of non-functional components of the breast tissue. So what happens is that during the course of the cancer progression is that this epithelial layer here, this kind of, you can see this looks like what the pathologist describes this to me, like a double layered, double string pearl kind of a necklace kind of thing. These two layers of epithelial and my epithelial cells, they are in this sitting very happy with the right polarity in the context of normal breast tissue. And what happens is that there is some genetic or epigenetic mutation that happens in this epithelial layer that causes these cells to start to proliferate and fill out the lumen. And what happens is that when these start to fill the lumen, they're going to exert this type of an outward stress to their surrounding extracellular matrix. And because of the third law of Newton that we are all familiar with, there's going to be a counterbalancing force or stress that is going to be applied by the extracellular matrix component on the epithelial layers. And this is going to be sensed by mechanisms called focal adhesions. These are the probes that cells use to sense their environment. So these forces are transduced through these focal adhesion kinases that link basically the intracellular and extracellular spaces through actomyosin cytoskeleton, and are going to be transported and kind of relayed to the nuclei, where they are going to start to change the cellular programming, in fact. So these forces are going to change how these cells behave. And this activation of these mechanosensory pathways causes some other downstream signaling pathways to be activated, causing these cells to basically start secreting some sort of soluble factors and cytokines that start attracting these immune cells and myofibroblasts to the extracellular matrix environment. And these cells, what they do is they're going to start secreting more and more extracellular matrix fibers, making the extracellular matrix stiffer. And that's what we sense when we are talking about tumors. We know they are stiff, but then that stiffness comes actually from the extracellular matrix component of them, or the collagen component of the breast tissue. So what happens is that the amount of the force that was being exerted on the epithelial cells now is going to increase, because now we have a stiffer component here. And as a result of that, there's going to be a positive feedback loop that is going to be formed that basically is exacerbated. But then over time, what happens is that at some point, these cells are going to start secreting what are called MMPs, or matrix metalloproteinases, which start to decompose the basement membrane and perforate it, and eventually these cells start to invade and basically go into the main breast parenchyma. So the in situ proliferation, that is like, these are still abnormal cells, but then they are not invasive. They are not going to attack any other part of the body. But now they basically break free from this and then start to invade. And as you can see, this is an entirely mechanical process. There's a lot of mechanical cues involved in this process. And not just in this early phase of in situ to invasive progression, but then over time, these mechanical gradients are going to be formed that basically cause the directional migrations of these cells from this basement membrane to breast parenchyma all the way to, invasion, and going all the way to the bloodstream and metastatic process. So there's a lot of mechanical cues and mechanical forces involved in this process. And these have been extensively studied in the context of tumor biology studies by growing these tumor cells on substrates of different stiffness and understanding the crosstalk between these mechanotransduction signaling pathways and other downstream signaling pathways that are basically related to pretty much all the classically known hallmarks of the cancer, such as, resistance to cell death, increased proliferation, the angiogenesis, the replicating immortality, and invasion and metastasis, as we talked about. And then morphological changes, all sorts of things. And then more recently, so these are studied well, but then more recently, there have been emergence of newer enabling hallmarks of the cancer, such as, evasion from the immune response. I apologize, I think my background got darker because there's the electricity in the university, they just do this. But for some reason, my room got darker, but I guess you should never mind the background. So let's focus on the talk then. So what happens is that these are these enabling characteristics, such as evasion of, escaping from the immune response of the defense mechanism of the body. So these are these enabling hallmarks. So there is this hypothesis that mechanical properties are also implicated in these, immune modulation. especially because we saw that tumor cells started to recruit these tumor infiltrating, immune cells. But then these are less studied in the context of mechanical properties. This is also basically because there are not many tools available to perform these studies in the context of tumor biology studies. So these stuff are known, but then the implications of them to the clinical setting remain unclear. And this is largely because of the fact that in the clinical setting, there's a whole different cycle for the treatment of, diagnosis and treatment of breast cancer. So what happens is that, the stiffness part or the changes in mechanical properties of the tumor microenvironment, its bulk manifestation, at some point it is involved. And people often identify the tumors through, imaging, elastography modalities or physical palpation, and that's how the disease is diagnosed. But then the first line of therapy in this context is just surgery. So what happens is that the tumor is taken out, there is going to be probably lymph node resection or lymph node biopsy, and then depending on the pathology of the tumor, there is going to be a bunch of prognostic and predictive markers that are identified to decide the treatment regimen. So what happens is that the histopathological arrangement of the tumor cells, and these diseases are very heterogeneous. They're a lot more heterogeneous than what the tumor biology studies have, investigated by growing like distinct specific cell lines on, substrates of different stiffness. In real biological situation inside the body, things are a lot different. The disease is a lot more heterogeneous. So depending on the histopathology of the disease or the status of the lymph node, what are the molecular expressions involved, such as estrogen and progesterone receptor status, the HER2 status, or sometimes gene expression profiling certain mutations, there are going to be some treatment regimens administered. So for example, if the tumor is only ER and PR, estrogen and progesterone positive, but the lymph node status is negative, the general understanding is that the patient can be spared from chemotherapy, and endocrine therapy should be sufficient to do so. And the patient is only going through the endocrine therapy because these markers basically predict that the response to the therapy is going to be more promising by going that direction. Whereas if the lymph node status is positive, then chemotherapy, or for example, HER2 status is also positive, then chemotherapy might be added to the treatment regimen. And then for HER2 subtypes, when ER and PR are negative and only HER2 is positive, then the anti-HER2 kind of treatments are administered plus chemotherapy and so on and so forth. And then for triple negative, maybe radiation is also added. So as you can see, there's a very different approach in the clinical practice to diagnose and treat and monitor the treatment response in the context of clinical setting that has nothing to do with our emerging understanding of the role of mechanical factors in the progression, in the onset and progression of the disease. So this is largely because there are not many tools available to measure the mechanical properties of the tissue in a non-invasive and non-destructive manner in the context of the tissue. So what happens is that biological tissue are considered viscoelastic, meaning that they exhibit both viscous and elastic properties. So these are like, biological tissue are not just elastic solid, they exhibit both this liquid-like and solid-like behavior. And this is best explained by a quantity called shear viscoelastic modulus. And this, mechanical properties of tissue or any other material are usually quantified by measuring the response of that material to an applied external load. And in the context of shear modulus, this external applied load is like a sinusoidal shear type of stress. And by shear, we mean that it's going to be applied parallel to the surface of the tissue. Usually, this is measured by sandwiching the tissue between two parallel plates and applying the shear stress, measuring the resulting shear strain, and calculating the ratio to obtain both the elastic, which is the real part of it, the part of the strain that is in phase with the stress, and imaginary part, this is the part of the strain that is out of phase with the strain, as the elastic and viscous or solid-like or liquid-like behavior of the tissue at that specific loading rate. And researchers have shown that there is a correlation between the magnitude of the elastic modulus, measured, of course, in the compression way, with the histopathology of the disease. So there is going to be a significant increase in the elastic modulus in malignant types of breast tissue. But then obviously this does not provide the resolution that we are looking for. It is highly invasive, requires a chunk of tissue to be extracted and measured, and basically not translatable. So there are different types of tissue, but then this metric is the most promising metric because it provides the largest contrast. So we really want to measure this shear modulus in the tissue because it is highly sensitive. It covers a wide spectrum across tissues of different, stiffnesses, and it's really representative of what we sense or an intuitive sense of stiffness or mechanical properties. It is also frequency dependent, so depending on loading rate, this metric can vary, but then at lower deformation rates, usually the viscous component in soft tissue is kind of a lot less significant compared to the elastic component of it. But then as depending on the differences in loading rate, the viscous component might start to take the center stage. So it's very important to measure the dynamics of this quantity as well. So like I mentioned, there has been an effort to incorporate the role of mechanical properties in the diagnosis of the disease, and ultrasound and MR elastography modalities are examples of cases where the physical sense of palpation has been incorporated in the clinical setting to increase sensitivity and specificity. But then these modalities, although useful in diagnostic setting, they don't have the resolution that is sufficient to distinguish between cellular and acellular components of the breast tissue. And as a result of that, cannot be used to measure mechanical properties at scales that are perceived by cells. On the other side of the spectrum, there are biophysical technologies such as atomic force microscopy that enable sensing mechanical properties at nano and micro scale. But then the problem with this technique is that the area search rate is very limited. These type of poking measurements can only be done over infinitesimal areas of only a few hundreds of microns. And here's where optics come into play, because optical techniques offer to bridge the gap between these two spectrums of technology and provide both the larger imaging field of views and also the resolution because of the proximity of the optical wavelengths to length scales of interest in measuring mechanical properties. And there have been an effort to develop different optical elastography modalities that enable to measure the mechanical properties at scales perceived by cells. So majority of these techniques rely on using, and basically good examples of those are different varieties of modalities of optical coherence elastography. These are elasticity imaging modalities that have been developed based on the parent technology, the optical coherence tomography. And the idea for these technologies is that there is going to be some external load applied to the tissue, and the deformation that is induced in the tissue is going to be measured by the underlying OCT modality to be able to extract the viscoelastic properties of tissue. And the most well-known example of it, optical coherence, the compression optical coherence elastography. The idea is to use a piezoelectric transducer to apply a static load to the tissue, and then use the OCT and basically the spatial correlation techniques to measure the deformation before and by comparing the deformation or basically the displacement before and after applying the external load to extract the deformation, and then by making some assumptions about the applied stress to extract the stress to strain ratio. But obviously in the context of heterogeneous tissue, there is no guarantee that the stress that is applied to the tissue surface remains uniform across the depth of the tissue. And as a result of that, majority of these measurements are qualitative. Although there have been efforts to basically make these measurements quantitative by using a stress sensing layer on top of the tissue to better map out the stress, at least on the surface, and propagate it down below the surface. Other wave-based OCE modalities are based on tracking an actuation wave that is basically propagating across the tissue, and by measuring the dispersion of acoustic waves or like other types of, waves that are propagating in the tissue, Rayleigh, lamp, or other types of waves, subsurface waves that are propagating across the tissue, to measure the velocity dispersions of these waves. And in this way, by relating the speed of these acoustic waves to the elastic modulus, extract the shear viscoelastic modulus across the tissue. But all of these are kind of active, so they involve applying some sort of a force and then tracking the response of the tissue, and a majority of them are limited to measuring only the elastic properties of the tissue, but not the entire dynamic response of frequency-dependent dynamic viscoelastic properties of the tissue. And that's how we decided to come into picture by introducing a new technology that is a passive technique based on the thermal internal vibrations of the tissue to extract viscoelastic properties from the speckle intensity fluctuations. So speckle, as you guys all know, is a phenomenon in optics that is formed when a coherent beam of light, such as a laser pointer, is scattered off a rough surface or a turbid media, such as biological tissue. So what happens is that when light rays go, the coherent light rays go inside the tissue, they scatter off multiple times from intrinsic scattering particles inside the tissue. And as a result of that, the returning light rays will have different optical phase shifts that vary at a rate that is commensurate with the movement of the scattering particles inside the tissue. So if those particles are free to move about, then the optical phase shifts happen at a faster rate. And as a result of that, we are going to experience a faster speckle fluctuation. Whereas if the particles are restricted in a stiff matrix, the light rays are going to basically experience slower phase shift changes. And as a result of that, we are going to experience slower speckle fluctuations and slower speckle decorrelation. If we are equipped with enough of a speed acquisition mechanism through a high-speed camera, we can extract or we can capture these speckle fluctuations, and by quantifying the rate of speckle fluctuations, get at least a sense of how stiff or soft the underlying material is. So for example, here, the two images, one of them is corresponding to halfway cured PDMS gel that is showing slower fluctuations, and the other one is from, the vivid speckle is from a water glycerol mixture that has some TiO2 particles inside it. And as you can see, for this low viscosity liquid, the speckle fluctuations are a lot more rapid. But then our goal is not just to measure a sense of stiffness, but what we actually want to do is that we want to measure the shear viscoelastic modulus, the same way that the rheometer measures that for us. And in order to do that, we need to come up with an algorithm and a way to process these speckle patterns and correct for a bunch of factors to be able to extract the shear viscoelastic modulus. First of all, what we need to do is to quantify the rate of speckle fluctuations. And this is achieved by capturing these speckle fluctuations or these speckle patterns by a high-speed camera, and then calculate the speckle intensity autocorrelation function. This is a curve that is obtained by cross-correlating speckle frames in a sequence of frames that are acquired at a high speed. The idea is that this speckle decorrelation curve has to be related to the mean square displacement of the scattering particles. But then the relationship between the two of them is not really straightforward, because the speckle fluctuations are not only modulated by the displacements of the particles, but also by the concentrations of them and the amount of absorption, optical absorption in the material. The second part of this calculation is to replace the mean square displacement of the scattering particle in an equation that is known as the generalized Stokes-Einstein equation. The idea behind this equation is that the thermal energy of these particles has to be equal to the energy that is required to deform the matrix, but of a certain stiffness by a certain amount. So in this way, we can relate the thermal energy, which is quantified by the Boltzmann constant times the ambient temperature of that tissue, the size of the scattering particles, the viscoelastic modulus, and the mean square displacement. And as you can see, the size of scattering particles also becomes important here. So we need some sort of an estimate of the size of scattering particles. So in developing this technology, what we focused on was to basically come up with ways that allow us to measure the optical properties and the size of scattering particles from the same speckle signal in order to basically close up that circle and make a well-rounded technology that enables us to measure the same quantity, shear viscoelastic modulus, that a rheometer would measure for us by just analyzing the speckle pattern that is emitted from the biological tissue. So just to show some results, we had previously established a correlation between rate of speckle fluctuations, here measured as a time constant of speckle fluctuation as a shear modulus for a range of phantoms and biological tissues and curing PDMS gels. But then our goal was not to just do a qualitative measurement, but be completely quantitative as much as possible and extract the same modulus from the speckle fluctuations. And these are some of the examples of the things that I was talking about. So these are the same glycerol water solutions, but then they have a different concentrations of scattering particles. And as you can see, if you quantify the rate of speckle fluctuations, we realize that as the concentrations of particles increases, because of the fact that each returning light ray has a larger number of scattering events involved in it, the rate of speckle fluctuations are going to increase regardless of the mechanical properties. So that needs to be corrected. But obviously, even by visual inspection of the speckle signal, you can tell that there's a significant difference in the scattering properties of the first and third sample here. So there should be a way to extract the optical properties from the same speckle signal. And also the other observation is that if we increase the amount of absorption in the sample, the rate of speckle fluctuations are going to slow down because of the fact that absorption is going to prune some of the longer optical paths that involve faster speckle fluctuations. So what we did is that we performed a bunch of Monte Carlo simulations and came up with this empirical equation that relates the mean square displacements of scattering particles with the speckle intensity autocorrelation function, where gamma and zeta were functions of the reduced scattering coefficient. So if we knew the reduced scattering coefficient, we were able to find a mapping between the G2T, the speckle intensity autocorrelation function, and the mean square displacements of scattering particles. And what we found out is that the information about mu of S prime and mu of A, optical absorption and reduced scattering coefficient, are actually encoded in the same speckle signal. If we perform temporal averaging of the speckle signal, we would obtain what is called the envelope of the speckle, or the diffuse reflectance profile. And if we look at the profile of intensity as a function of distance from the illumination center, when we are using a focus beam to create a speckle signal, the slope of this curve is actually telling us some information that from which we can extract the optical properties. So that's the solution that we came up with to correct for the role of optical properties and basically map out and extract the displacements of the particles from the speckle intensity autocorrelation curve. When it comes to measuring, so you remember we had another factor, the optical, the size of the light scattering particles. So that also needed to be estimated. The other observation that we made was that if we look into the polarization attributes of laser speckle, the information about the particle size is encoded there. So, for example, if we look at the copolarized component of the speckle, this is the speckle. So basically we illuminate the sample with a polarized laser light and then look into the component of the light that retains the initial polarization state. What we realize is that for smaller particles where they fall in the Rayleigh scattering regime, the remitted speckle pattern resembles a dipole radiation pattern or an elliptical form. Whereas as the particle size increases and starts to match the wavelength and increase beyond the wavelength, the pattern evolves to a clover-like shape. So by observing this evolution of laser speckle, average laser speckle or the envelope of laser speckle in the copolarized channel, we were able to come up with a calibration curve that somehow gave us some information about where the particle size stands. But then we weren't completely happy with that. So this is another example of the size of the particles and how a speckle pattern would look like. So our goal was to basically better estimate the particle size from speckle fluctuations, and we did this in in the context of other optical light scattering techniques. So we know that light scattering has long been used to measure the particle size using DLS, for example, by looking at the fluctuations of the backscattered light, very similar to what we are doing for measuring the mechanical properties, or in laser diffraction by looking at the diffractive pattern of light. But then both these techniques require diluting the sample to a single scattering limit in solvents of known viscosity. And this is something that we didn't want to do. We wanted to do it in intact tissue in its native state. So we wanted to look at the same speckle signal that was, scattered from the tissue and use that information to extract the particle size. So we started to more closely look into these, evolution of speckle patterns as the particle size increases. And what we observed was that there's a lot more information in the speckle signal about the particle size. And this is stemming from the fact that when you have smaller particles, the light scattering, as I mentioned in my former slide, is more isotropic. So if you illuminate the sample by a polarized light beam, because of the light being more isotropically scattering, a few scattering events are sufficient for the light to completely make that 180-degree turn and come back to your detector. And because of the lower number of scattering events, there's a higher chance that the light that comes back to you at the backscattering, in a backscattering geometry, could retain its polarization state. And then the light that actually goes through multiple scattering events and eventually loses its memory of the initial polarization state is going to basically have a higher propensity to come back to you at a cross-polarized state. So for a small particle, the path length distribution of the copolarized and cross-polarized speckle are going to be significantly different from each other. As a result of that, you will have a brighter copolarized component, and also the rate of speckle fluctuations are going to be slower in the copolarized channel compared to the cross-polarized channel. On the other hand, as the particle size increases, the scattering becomes more and more forwardly directed. Because of that, the path length distribution in the cross and copolarized channel are going to be very similar. So the difference in the fluctuations of the speckle patterns in the co and cross polarized channels are going to be diminished. And as we saw before, the envelope of the speckle is going to be, evolving from this dipole-like pattern to a clover-like shape. So we are going to have the secondary pairs of lobe growing that are coming from multiple scattered light in the cross-polarized channel. And this is the polarization axis. So the dipole is along the polarization axis. The cross-polarized component will continue to have a clover-like shape, but what happens is that the circularity of this pattern would change as a function of particle size. And the pattern starts to become more and more circular and more lobulated as the particle size matches the wavelength of the light. I think I'm going to need to turn on the light. Give me a second. Much better. Sorry about that. So as you can see, speckle pattern is packed with information about the particle size. And what we did was that we decided to perform a comprehensive Monte Carlo simulation to better understand the relationship between optical properties, particle size, and all of these attributes, and came up with a whole set of Monte Carlo simulated envelope of the speckle and speckle intensity autocorrelation function to basically build a prediction model that allowed us to predict the scattering particle size from speckle intensity fluctuation. So all the qualitative things that we talked about, we basically translated them into 4 different attributes, basically being the intensity of the envelope of the speckle along the short to the long axis in the copolarized channel, the circularity of the cross-polarized speckle envelope, the radial extent of it, and the differential decorrelation rates of the speckle intensity autocorrelation curve in the cross and copolarized channel. So we came up with these 4 attributes, and then based on these, we basically simulated all of these 4 attributes as a function of optical properties and particle size. And what we realized is that the relationship is pretty involved. It's not a linear simple relationship and does not warrant a simple linear regression model that allows us to predict particle size just by a simple linear regression model from these attributes. So we turned into a clustering approach that basically we pulled these 4 attributes and came up with we plugged them into a k-means clustering algorithm that divided this space for us into 5 different clusters, and for each cluster it came up with a multiple linear regression model that would give the particle size as a function of these attributes. This is the scatter diagram of the particle size. The size of these markers represents the volume of the marker represents the particle size, and then these are the 4 attributes that are quantified there, and the cluster number is encoded in the color. The 4th attribute is represented by the shading of the markers. So the workflow of the measurement would be to measure the speckle in the 2 cross and copolarized channels, and then come up with these 4 attributes, find the closest cluster that has this closest Euclidean distance to this vector of attributes, and then use the regression model that corresponded to that cluster to predict the scattering particle size. So we validated this in the context of standard polystyrene particles and realized that our model is pretty accurate as compared to DLS. So basically it has a significant strong correlation with DLS measurement, a very small offset in the order of 24 nanometers, showing that we are able to estimate the particle size in a relatively wide range between a few tens of nanometer to a few micron. This is the same range as DLS offers, the standard dynamic light scattering instruments offer. So we were pretty happy with the way that we managed to extract the average size of scattering particles from the speckle signal. And we actually also took the next step to scan the biological tissue samples and find out the spatial distributions of the size of the particle across the tissue landscape. And this is something that we are still working on. We are hoping to add more resolution to this and be able to measure the particle size with a higher resolution to make the particle size distribution measurement possible in the context of intact tissue. Going back to our phantom models, basically having figured out the entire cycle of measuring the shear viscoelastic modulus from speckle fluctuations, we validated our measurements in various biological fluids and phantom gels and compared them with rheometer measurements and also atomic force microscopy. And we were pretty happy with the correlations and significance of these measurements. So we were pretty happy that what we are measuring kind of correlates with what we would get from a standard mechanical testing device. Having validated the technology, we decided to move it to the clinical setting. And we basically built a microscope around this idea that allowed us to capture speckle fluctuations or speckle patterns at a high resolution through an objective lens. And then by scanning the sample and performing a pixel-wise cross-correlation of speckle patterns, that allowed us to map the shear modulus across the tissue landscape. So we formed a study around this. We collected specimens from about 148 patients undergoing surgery at MGH. We performed our imaging. Now we are going to call this laser speckle rheological microscopy, this microscopy platform. And we did histopathological analysis, collected the clinical information about the subtype of the tumor, the histopathological grade of the tumor, expressions of molecular receptors, and the lymph node status, and automatically co-registered the shear maps with histopathological sections. We also did some texture analysis on the maps of the mechanical properties that we had obtained across the tissue landscape. And also on the side, we looked into the concentrations of stromal tumor-infiltrating lymphocyte as markers of the immune response across the tumor landscape. So this is an example of a normal breast anatomy that we talked about. You can appreciate the adipose tissue, the wavy, soft collagen, and terminal ductolobular units and ducts and lobules that you basically observe there in purple in the histopathological section. We had two different types of staining. This is the picrocereus red stain that visualizes the collagen. You can see the collagen is pretty wavy and happy and small fibrils and all. We don't see signatures of bundled up stiff collagen in the context of normal breast tissue. And we have our shear map here, the map of shear viscoelastic modulus that identifies the adipose region as the softest region here, and also the sections that correspond to the glandular tissue correspond to softer, lower viscoelastic modulus region inside the stiffer, relatively stiffer stromal region. So this was our normal breast tissue. We did that in the context of all of the normal and abnormal specimens, about 250 specimens that we had collected. And we came up with these correlations. So our measurements did correlate the overall stiffness of the specimens, overall shear modulus average over the entire tissue specimen, did correlate with collagen content. This is important because collagen is considered the main extracellular matrix protein that is responsible for the tensile strength of the tissue. So it's kind of, should correlate with intuitive sense of stiffness in tissue. And seeing this correlation was promising that we are actually measuring mechanical properties in the context of tissue once again as another validation. We also did conventional rheology on selected specimens in this subset and in a subset of specimens, and we found out that our measurements are correlated, or average shear viscoelastic modulus was correlated with what is measured with a conventional mechanical testing device. Moving on, we wanted to look at it in the context of the pathology of the disease. So this is an example of an invasive ductal carcinoma that also harbors some ductal carcinoma in situ. These are blown out regions of ductal carcinoma in situ. We can appreciate the proliferation of these purple things are the cells. And as you can see, they are filling out the lumen. They don't have that double string pearl necklace anymore. They are like multiple layers of tumor cells, but they are still confined within this basement membrane. They haven't invaded. And as you can see here, the collagen fibers are still rather thin and wavy, and there's not much stiffness around this happening here compared to the invasive component. These are the tumor cells that started to breach out from the basement membrane, and they're starting to basically invade the breast parenchyma. And we can appreciate that our modulus shows some increase in the extracellular matrix components of this invasive carcinoma compared to the in situ component. This is another subtype. So as I mentioned, in the context of clinical setting, it's not like tumor biology studies where you have just limited cell lines and you grow them on substrate of different stiffness. The disease takes on many different realizations with many different prognostic factors. This is another case. This is an invasive mucinous carcinoma of breast. In this case, this is like a tumor of better prognosis. This is a softer type of tumor. It's a gelatinous. The other name for it is like gelatinous carcinoma, in which tumor cells are pretty well differentiated and they float in pools of mucin, like a mucus that they basically secrete. So the tumor is pretty whipped and has this kind of slimy feeling to it. It's actually happens in older elderly patient, and it's associated with better prognosis. And if you perform ultrasound elastography on these, they are very much associated with a lot of false negatives because they are softer tumors that if you just think about tumors as being just stiff, you wouldn't catch them with, based on that criteria on elastography modalities. So this basically accentuates the fact that mechanical properties can take a lot of twists and turns in the context of the clinical setting. So you appreciate these pools of mucin showing up as softer regions in the shear map here that are basically invading against the regular conventional stromal component. And you can appreciate the contrast between the collagenous stromal regions and the mucinous regions. This is another subtype. This is called an invasive papillary carcinoma. This is a special subtype of breast cancer. These are also softer, friable kind of masses that bleed spontaneously even in the absence of invasion, and they are characterized by tumor cells that form like a structure like a tree or a bush around the central fibrovascular core. You can appreciate the increased stiffness in the fibrous core here. They form these leaves, and these are the blood vessels that basically feed these tumors, so they can bleed. And you can appreciate the basically the perfect registration of the shear map with the histopathological sections. This is the collagen fibers that are better visualized in the PSR section. And this is a zoomed in view of that. You can see even the subtle differences in the blood region and the cellular region in the shear map. Now, this is another subtype. This is an invasive micropapillary carcinoma. This is a very aggressive subtype that is, characterized with, usually they are lymph node positive. They are very aggressive subtype. And you can appreciate the significant contrast between the stroma and the epithelia of this tumor. We have a significantly stiffer stromal component here, and you can appreciate the strings of collagen that, basically extend in the tumor. These are the tracks that tumor cells hold on to, and they basically do the contact guidance, allowing these fibers to make their way into the stromal component. So it's interesting that our technology is picking up all of these basically histological features and replicates or basically mirrors closely the histopathological findings. So this is interesting, but what are we going to do with these maps? So we said that we want to look at it at the scales that are perceived by cell. We said that the benefit of this technology is that it's not just going to give us one number as a measure of stiffness, just like other elastography modalities, has the resolution to differentiate between cellular and acellular components. So we can study the interaction between the epithelial component and stromal component. So let's closely look at this and see if we can get more information from these maps. So we decided to do some texture analysis to better understand the micromechanical heterogeneities. And this is important because in the context of clinical setting, breast cancer is characterized as being a very heterogeneous type of disease. And even in patients that have the same diagnosis and they are given the same treatment, the response to treatment can be significantly different among different patients. And this is attributed to the heterogeneities in the context of this disease. That not only that the disease is different among different people, but then within the same tumor, different regions of tumor can exhibit different properties. And although the treatment addresses the aggressive behavior in some subsections of the tumor, there are other parts of the tumor in terms of its epithelium and its stromal component that can escape the treatment and don't respond to it, and then create residual disease and then come back and relapse. So we wanted to know how to quantify these heterogeneities. So we basically turned to mathematical definitions. We knew that gradient is a big factor. The gradient of stiffness is something, or a gradient of the shear modulus is something that basically can trigger the migration of the cells. So what we did is that we calculated the gradient at the tumor stroma interface for the tumors that we could identify the invasive front. Invasive front refers to where the tumor cells meet their stromal component, and this is where they are pushing against normal tissue. They want to invade it. So we wanted to know what the gradient looks like there and how does it correlate. So this is studied in the context of tumor biology studies, but we wanted to know if it correlates with clinical markers. We also looked into the contrast between the tumor epithelium and tumor stroma. We know that more aggressive tumor subtypes have softer tumors because they are very sneaky and they want to make their way through stromal pores, and they do that by squeezing and passing through the pores to basically reach their goal, which is basically metastasizing to other parts of the body. And then increased stiffness of the stroma is associated with poor prognosis. So we wanted to know if the contrast is going to tell us something. And we also looked into the overall entropy of the tumor landscape as another measure of heterogeneity. So in our subset of specimens that we had collected, we quantified these for all of the different subtypes. We quantified the overall shear modulus, the stiffness gradients, the contrast, and the entropy, and basically looked into these parameters in the context of prognostic markers such as the tumor subtype, the grade, estrogen and progesterone status, HER2 status, and lymph node status. The other thing that we looked into, we said that, okay, now we have the tumor, we have the co-registered H&E slides. So let's see if we can look into the correlation between stiffness and mechanical properties of the tumor microenvironment and stromal component, all of these micromechanical heterogeneity indices, and the immune response in the tumor. Because really, honestly, we can look into the H&E slides and identify tumor infiltrating lymphocytes from H&E sections. And there is an effort to basically assign a immunological grade to the tumors based on that. Although the prospect of immunotherapy in the context of breast cancer is still an evolving frontier, but then if the day comes that we want to target this cancer with immunotherapy, there should be an understanding of the immunological state of the tumor and how much of responsiveness there is and how much immune response is there inside the tumor context. So what we did is that in the context of same specimens that we have calculated, we looked into the correlation between these micromechanical heterogeneity indices and the TILS score, which is the concentrations of the tumor infiltrating lymphocyte in the intratumoral stromal component of the specimens that we have collected. So this is a case of, and as you can see, as I basically flip through these slides, you can see that there is a clear correlation between the percentage of tumor infiltrating lymphocyte in the stromal component and the overall stiffness of the tumor. So this is a tumor that the previous one was a tumor that had only 5% of its stromal component being populated. So this is smaller purple dots in the stroma in the pink area correspond to the TILS cells. And you can see this is a case where you have 20% of the stromal area covered by tumor infiltrating lymphocyte. And compared to the previous one, we appreciate the reduction in the overall stiffness of the tumor landscape. We also did measure other mechanical metrics and looked at them in the context of the tumor infiltrating lymphocyte to see if they have anything to do, if there is a difference in the gradient or the contrast or the entropy. The other observation is that, so this is another case, you can see that the tumors are serially becoming softer, whereas the concentrations of TILS is increasing in them. So this is a tumor that has 50% of this stroma covered by immune cells. So there's a lot of influx of immune cells to this tumor, and it's like a softer tumor. And eventually, this is one that has like 57% of its stromal component or more than that covered with these blueberry-like, immune cells. So obviously, there is a significant correlation between, reduction in the overall stiffness of the tumor microenvironment and the infiltrations of the immune cells. So we basically wanted to look into these micromechanical heterogeneity indices and overall stiffness of the tumor in the context of known prognostic markers to see if there is any associations between them, if these micromechanical heterogeneity indices can tell us something about aggressiveness of the tumor on top of the existing techniques to better streamline the heterogeneity of the disease or open some new avenues for diagnosis. So what we realized is that in aggressive subtypes, so all of these heterogeneity indices and overall stiffness tend to increase in more aggressive subtype. This is interesting because, there are maybe different metrics of aggression, but it looks like that there is a common denominator between all of them. The other aspect that we realized was that the tumor histopathological grade tends to decrease with the overall stiffness. And that could speak to the fact that higher grade tumors tend to be more epithelial than stromal. Tumor cells are growing so fast that basically they overtake the entire mass and outgrow their scaffolding. So that might speak to that aspect of the tumor pathology. The other observation that we had was that the gradient of stiffness and the contrast seem to increase in ER-positive tumors, whereas the overall stiffness and the gradient seem to be correlated with the progesterone receptor status. And then lymph node status seem to be correlated with the gradient of stiffness, but then inversely correlated with the gradient. On the other hand, TILS score was correlated with reduction in the shear modulus, reduction in the gradient, and reduction in the entropy, which might mean that if the tumor has a lower gradient, it allows tumor infiltrating lymphocyte to better infiltrate the tumor microenvironment. This is an observation that is expected from other immunological studies that suggest that the stiffer tumor microenvironment might prevent the infiltrations of immune cells into the tumor microenvironment. We also did a multivariate regression analysis to basically control for the effect of all of these clinical markers and identify which of them are actually independently associated with the micromechanical heterogeneity indices. And this is the observation that we make. These are the trends that are actually significant, which is pretty interesting. So this basically tells us that some of these metrics can basically differentiate tumors of different and can serve as common denominators of aggression among different criteria that are basically developed to reduce the complexity of the disease, but then in turn have increased the heterogeneity. So maybe by using these micromechanical heterogeneity indices, we might be able to better streamline the diagnosis and come up with a more cohesive understanding of aggressive phenotype based on the mechanical properties. Moving forward, our goal is to basically incorporate these micromechanical heterogeneity indices in the context of prognosis, as we talked about, to help with streamlining the subtyping and grading of the tumor cells, and also maybe help to predict the response to different types of therapy. In the context of developing new therapies, we found out that there is an inverse correlation between mechanical properties and the influx of immune cells in the tumor microenvironment. That might be a key to the design of new immunotherapy techniques, where the goal is to make sure that the engineered immune cells are successfully able to make their way to the tumor microenvironment and target the tumor cells, and basically suggest that maybe re-engineering the tumor microenvironment mechanical properties might be a way to guarantee the success of these new lines of therapy. So basically, our goal is to incorporate these findings and these understandings over long term to the clinical, workflow of breast cancer treatment and diagnosis to better aid and shift the paradigm of the cancer treatment by adding this knowledge that has so far been only limited to tumor biology studies, and basically translated to the clinical practice and the clinical setting. So with that, I would like to thank my mentor, Dr. Simanti Nadkarni, where all of this work has been done in her lab, my former lab mates and collaborators and funding sources, and I'm open to any questions that you might have. But before that, let me just turn on the lights because it keeps turning off and I feel like it's kind of distracting. Just a second.
All right. Oh, well, let's thank the speaker. Okay. Any questions from the audience? Anyone? I can start. So do you see any questions? Probably not. So okay. So in terms of so it sounds like you guys have been using red probably 630 nanometer ish kind of laser. I mean, so did you guys have a chance to explore different wavelengths? Whether 630 nanometer is the best, or different wavelengths might have a different sort of implication. Can you comment on that?
Yeah, great question. So 633 nanometer, we started using it because like early in these studies, we were looking for a laser that has the longest coherent length, and it's very stable, so that it does not, cause a speckle decorrelation just because of the source instability. And Hine lasers, they are our most stable type of laser. Later on, for example, this is one example that we've used this technology. As you're aware, in Dr. Nadkarni's lab, this technology is being moved to blood coagulation studies. And there, because of the higher absorption of 632 in the blood, the closest wavelength that still, we can escape the absorption bandwidth of the hemoglobin is 690. So we basically switched to a 690 source. I would imagine that in the context of other type of diseases, for example, if you want to use it in the context of melanoma, you probably want to go to infrared or wavelengths that you can skip the absorption of chromophores in that wavelength. So depending on what type of chromophores you have or what type of source of absorption you have, you can eliminate the problem of low role of absorption also, in the modulating of a speckle fluctuation by switching to a laser that has minimal absorption in the wave, in the tissue of interest. So that's a important factor to consider. But also stability of the laser is another factor. So when we switch to laser diodes at 690, we did not have the same stability, or lasers had a shorter lifetime in that context because they weren't stable enough.
I see. Yeah, that's interesting. Any questions? Okay, Andy.
Hi, that was a good talk. I was wondering what the thickness of your samples are and what it's the time scale that you have to do your measurements.
Right, very good question. So our samples were tissue, fresh excised tissue, and they were like a couple of millimeters thick. Our technique right now is not depth resolve. So what we were seeing is that our measurements were pretty much correlated. And then we submitted the sections for histopathological analysis. And what happens is that in histopathological analysis, they would obtain sections every 100 micron. And what we saw was that our measurements were correlated with the measurement. It's a depth integrated technique, right? We were correlated up to 500 micron thickness. So I think that answers this aspect of your question. I forgot the second part of your question.
How long do you have to collect the data to be able to tease out all this information? Like you have to have a time, course, right? So.
Right. So for each 500 by 500 micron area, it would take us 1 second. If we have a bigger piece of tissue, like 2 centimeter by 2 centimeter in terms of its dimensions, with the newer M2 SSD drives that, increase the writing and reading speed of the speckle frames to the computer, it would take us about 10 to 15 minutes to image something that is a 1 centimeter by 1 centimeter.
And what was the frame rate, for the camera?
Oh, the frame rate depends. So right now for this study, the frame rate was about 250 because we were just doing up to 40 hertz. But if you want to probe mechanical properties at higher frequencies and start to look into the differences in viscosity and elasticity, we have been using our colleagues also have been using frame rates up to a few 100 kilohertz.
100 kilohertz. Okay.
Yeah, like 1 million frames per second kind of camera would be ideal, but then you would need a brighter laser.
Any other questions and thoughts? Good. Okay. Good. Well, let's thank Zeinab again. Thank you so much. I know it's pretty late time over there, so safe driving home. And I'll see you in next conference. Bye. Thank you.
Thank you. Thank you very much for the invitation. I really enjoyed presenting for your audience.
Thank you.
Thank you.